I'd like to welcome you to episode 110 of Chairside Live. Today we have part 2 of my interview with Dr. David Hornbrook. And David and I get the opportunity to discuss a couple of things that I really wanted to hear his aesthetic take on. For example, implant aesthetics. What's he currently using in the anterior? When it comes time to restore an implant, it can be a very difficult area to get a good aesthetic result. And David shares some of his secrets with me. I also want to ask him about the Nixon ditch. If you're not familiar with that, no, it's not in front of the Nixon Library in beautiful Yorba Linda, California. The Nixon ditch was something devised a long time ago for you've got an endodontically treated tooth, and even though you've got a nice, say, tooth-colored buildup and an all-ceramic crown, because it's been endodontically treated, the root is dark and it's showing through some thin gingiva. And this was something Dr. Bob Nixon came up with to help us get a better aesthetic result. And I asked David if he still does that or if he has an alternative to that. But first, we've got an interesting case of the week for you this week. It's a double arch tray that a dentist sent in, and they also happened to send in a full arch impression because they weren't sure about the margins on either of them. This ended up paying dividends in the end because, as you'll see, there was something a little off about this double arch impression, and in came the full arch impression to save the day. Let's take a look at that now. For this week's case of the week, I thought it was interesting because I spent a lot of time talking about how, well, the vast majority of impressions we get are in double arch trays like this one, and this happens to be one of my favorite ones, the Clinician's Choice Quad Tray Extreme, just because of how stiff this thing is. I mean, you just really can't bend it at all because it's all metal, not plastic. So you can use really any impression material you want inside of it. If you have a more flimsy plastic tray, you need a pretty stiff material inside of it, almost a putty, really, to make it so that it won't distort while you squeeze it, which is why I like this one. And I've often said that, quoted research saying that a well-done double arch tray like this is actually a better bite registration than even 2 separate full arch impressions that have been poured up with a bite registration sent along with it. But this is kind of an interesting case because it's something that happens fairly often in the laboratory where you look at this and it actually looks pretty decent. The doctor sent another impression with it, but wasn't quite sure what happened there at the margin. Actually, there was a little retraction cord in there that the doctor pulled out and was really close to the margin, so the doctor sent another impression. And when the laboratory went to make it, they noticed when they turned it over that even though the patient did not have a second molar on the arch that was being prepped, as we look on the other side, we do in fact have a second molar on the upper, and that in fact was in contact with the tray, with that distal bar on the Quad Tray Extreme. So if I were to hold this up to the light, and essentially we do have a light pointing down on that, you'll see that you really don't see any light on the unprepared teeth adjacent to the preparation. So this is certainly something we want to see when we hold it up to a light, is that we do in fact have some sort of contact on those unprepared sets of teeth apart from it. Here, I'll pretend it's the middle of the night and I'll take out my iPhone and turn on the flashlight. And typically when you've got unprepared teeth in contact, as you should, you'll see light right through there. If I set it right on top of my iPhone, you can barely just see a little, but it's pretty clear that those teeth aren't in contact with one another, and the reason why they aren't is the patient's hitting on that distal bar. The tray just needed to be positioned a little farther to the distal, and it was fine on the prepped arch because there wasn't a molar there, and it probably looked like there was plenty of room, but obviously on the opposing there wasn't. So what the laboratory did in an effort, because I'm one of the reasons, I'm constantly telling the technicians, slow down. Don't be so quick just to call the doctor and ask for a new impression. Let's see if there's a way we can work with it. And it's not that I even feel bad for the doctor, it's that I feel bad for the patient. Coming back in, getting re-anesthetized, having a cord packed, having another impression taken. And so we're always kind of looking for a way to make it work. Unless the dentist has on their permanent notes, call me anytime there's an issue. So they mounted the case as it was here, saw it was off obviously, and so they hand articulated the models and put them together and felt pretty good about the hand articulation that they had between this upper and lower model. And then they milled the Bruxer crown that the doctor requested. This, by the way, is right out of the mill. If you ever wondered what a Bruxer crown looked like as soon as it's being done milled. It's been milled here and then sandblasted a little bit just to clean it up. and no staining or glazing at this point. If Rella Christensen had her way, and she's getting her way more often because we're trying to find ways to polish this and not have to stain and glaze it, because the glaze that we put on the surface of this crown is actually rougher, actually wears the opposing tooth structure more than the zirconia itself. The zirconia oxide is actually very smooth. So this is just literally right out of the mill, and nothing's been done to it yet, which is why it looks like it's in an unfinished state. 5 years ago, this would have been white, the same color as my shirt. This would have been a very white color that you would have seen here, and it would have needed to be stained and glazed a lot. But today we're able to do it shaded, and so this is coming out pretty close to the A2 that the doctor has requested in this case. And so when this comes out and gets tried onto the model, the first thing the technicians want to know is about the bite, and it's high. So it's holding everything apart. So the bite is high on this, and they realize that, okay, well, our hand articulation didn't work. We didn't get these two arches close enough together, because even though we tried to hand articulate it, this bite is high. And as they look through the doctor's case, they noticed that the doctor sent a second impression, and it wasn't as good as the first in terms of marginal quality, but it was, when you look at it, a nice, full arch impression. But when you compare the two preparations themselves, even though we have a little cord there, it's a little bit cleaner on the double arch impression than it is on the full arch impression. But our success rate with hand articulating models goes way up if we hand articulate full arch models than when we try to hand articulate a double arch tray. And so we just called the dentist and said, hey, if you have the patient come by, no need to re-anesthetize them, just take an opposing impression. And they did. So this is an alginate replacement material. I'm in love with these materials, especially being here in the lab, is we can pour them multiple times. They're stable for 2 weeks. And for a dentist who's on the East Coast, sending it to a lab in California, taking an alginate impression, wrapping it in a wet paper towel and putting it in a baggie, it doesn't matter, especially during the summer. By the time it gets to us, it's shrunken. It looks like a Dead Sea Scroll by the time we take it out and try to pour it up. It looks like parchment paper, even though it was a wet paper towel. If you're going to send an alginate impression, pour it up in your office and send us the stone model, and pour it well. Or just do this, take an alginate replacement. They're just as easy to take. It's basically a cheap polyvinyl impression, a cheaper version of this. It stays dimensionally stable for, again, 2 weeks. We can do multiple pours on it. And so what we were able to do was just have the patient come back, and the dentist took this impression instead of taking a new one of these. This is 2 minutes of the patient's time. This is another lower block, temporary comes off, cord being packed, being very uncomfortable. And then we were able to pour up this model. Of course, we already had the crown. And then pour up the opposing. And now when we go to hand articulate this, all of a sudden we got lots of contacts of teeth on both sides in the posterior, and we have it in the anterior as well. And we can take that same Bruxer crown and put it into place. And now everything is fitting the way that it should fit as this is in place. And it's because of the fact that we had this full upper and the full lower. And I asked him, I said, just for fun, let me see what this would look like if we poured this impression and then just mounted it all on its own without doing the hand articulation correction. Of course, that's what it looks like when the patient bites on that distal bar. You can see it's absolutely wide open there. The pin was up a little bit, but it's still wide open, as you can see when we're down, clearly a full millimeter and a half between those teeth, because the patient did have that second molar that was hitting there and keeping them from coming all the way together. So for the dentist, it would have been nice. It's always a good check for the dentist or the dental assistant to take these double arch impressions and hold it up to the light and see if you can see light coming in. And we should have contact on all these teeth adjacent to the prep where there is, in fact, an opposing tooth across from it. We should have light shining through there, and it should be very easy to see. The second thing is that if you do happen to see an impression like this and you note that the bite's off a little bit, know that if we try to hand articulate this, the chances of it working are about 35-40%. And like you saw in this case, even though we hand articulated it based on this 1, 2, 3, 4 other sets of opposing teeth here, we still didn't get the correct bite. And had that crown been sent to the doctor and tried in the patient's mouth, it would have in fact been very high, and you probably wouldn't have been able to adjust the occlusion enough and still had the crown look decent. So it probably would have been a redo. In this case, we've seen doctors notice this issue and send a little bite registration in with it, just on the occlusal surface of the third of the prep and the occlusal third of the opposing tooth, and that's fine. But really, probably the best way is just to take another one of these double arch tray impressions, unless it's been so long that the gingivas completely come back against the tooth again, but at the same time. So even though we know most dentists for a single unit aren't going to take a full arch like this, and I wouldn't even try to switch a doctor who's doing this technique over to this technique, but do know that if you are doing this technique and you're comfortable with doing it and using this much impression material, that if in fact, the bite registration's a little bit off, this gives us a great ability to hand articulate the models together and really come up with something that's going to fit well together. Whereas if the bite's off on a double arch tray like this, we either need a separate bite registration or preferably a whole new impression in a double arch tray like this. And so while, when properly done, this double arch tray does kind of represent the state of the art in terms of having a nice occlusion to be able to work with once we mount these models, when things go wrong on one of these double arch trays, they go really wrong. And when things go wrong here and we have a bad bite registration, we can still save it. So again, like most things in dentistry, there are some pros and cons to both ways of doing it. But with the vast majority of impressions that we receive being for 1 or 2 units of crown and bridge being done in these types of double arch trays, make sure you look that the patient didn't impinge. Try in the tray without any impression material in it before you actually take the impression. Have the patient close 3 or 4 times and make sure they can get all the way done. And that little rehearsal for you and the patient, you're going to stand a much better chance of getting this tray back in the right position. And then once it comes out of the patient's mouth, take a look at the margins and just hold it up to the operatory light or the light in the room itself. And look and make sure that you can see some light showing through the contacts of the teeth, the unprepared teeth adjacent to the preparation. Hey, there's another area where, as a laboratory, we, with our dentists, kind of struggle for aesthetics, and that would be anterior implant cases. I know you work with some great specialists down there. I know you're periodontist, and I don't know if Peter places your implants or who you do implants with. Is this an area that you find, like that single tooth implant on a central incisor, is this an area where you find this is about the toughest aesthetic challenge you might run into?
Well, I think anytime you're going to replace a single restoration, so if we're talking about a single crown, that in itself is, you already have 2 strikes against you. So that comes up first, whether it's a crown prep of a natural tooth or an implant. Then you add the fact that we don't have total control of contours all the time because we're not sure what that soft tissue or even the bone's going to do after implant placement. I think it's gotten very predictable with bone level implants. And so now we can develop contours, the emergence of the implant itself, the implant abutment. Also the abutments being designed by laboratories via CAD/CAM or waxed. We're doing a lot of UCLA style abutments, but we're, instead of waxing and casting gold, we're waxing and pressing lithium disilicate, cementing it on that. So, and as at Glidewell we're using CAD/CAM, and you're actually developing that contour versus having just a straight cylinder that we had for years and years. So I think if a dentist wants to take the time, or should, but if they want to, develop those contours by having a great temporary, I think it's a disservice in the anterior to give our patient a flipper. I think that's below the standard care, in my opinion. Posterior, I still wouldn't, but that's an option. I think we need to develop that. The manufacturers, and you look at what Glidewell's doing with their custom abutments and their provisionals, I think it's gotten really predictable. But it all starts with the relationship from day one, where the general dentist, restorative dentist, is the quarterback telling the surgeon where they want that implant placed so that we can develop a great contour. Where I've seen problems is where a patient shows up in my office and says, "Oh, my surgeon says my implant's ready." And it's sticking straight out like this. It's, ready for what? To be buried and we can do a bridge? Or to be, and so I think that's the important thing. And I think too many times clinicians, us as dentists, we just send a patient to the surgeon and says, they need tooth number 8 extracted. They need an implant placed there. Tell me when it's ready.
Right. And digital treatment planning really stands to to change all that and kind of designs it, with the end in mind, starting with here's where the tooth or the restoration needs to be. Ergo, this is where the implant needs to be, and working backwards like that. And then when I first saw my first surgical guide, I decided I wasn't afraid to place implants anymore, but I don't think I would have ever tried it without having a surgical guide to make it easier for me. Hey, can you think of the last thing that you added to your practice, whether it's a product or a procedure or anything along those lines that really excited you, like the last really kind of fun thing that you started doing, or the last great case, just anything along those lines if it comes up?
Well, shoot, I'm trying to think. Just recently, and again, I'm going to go back to that lithium disilicate over the UCLA type of abutment. I love that. I love it for a lot of reasons, and again, you're primarily doing full zirconium, which I think that's a great option. But I'm sure that a lot of dentists that are listening now have had a full zirconium abutment break, especially early on, internal hex, and you're torquing that down, and you hear a crack, or I've seen some of these Atlantis abutments. Who designs these? Like, you think of like an Indian, because they're like teepees. They got these thin little shells. You put my driver down there, and I broke 3 or 4. I'm sure it was my assistant that bumped me. I'm sure it wasn't my fault. But where I've actually broke half the coronal aspect of the abutment off because they're so thin. And so I was struggling with that a little bit on some of the cases. And I like the concept again of a UCLA abutment, where you have titanium to titanium, so it's machined versus milled. I can torque that down to my 35 newtons and know I'm torquing titanium against titanium. But with a gold abutment, now I'm back to, okay, how am I going to hide this gold, which is, that take 2 strikes against us. So we're doing this lithium disilicate, where again it's waxed and pressed. You could mill it. Again, CEREC has the what they call the tie base abutment, something we've been doing now for almost 5 years, and we've had really, really good success with it. And the other thing we're doing, because we're doing bone level in the anterior, I like my margins of my implant abutment, or the crown, I like to be at gingival. So lots of times I'll have 3 to 4 millimeters between where my crown margin is and actually the implant itself, the platform against the implant. And you've seen this, and I've seen this, where if it's bright white like the early zirconium was, and it basically has a thin biotype, or you use a metal abutment thin biotype, you're going to have that bright white or kind of grayness through the tissue. We're staining that pink. We're actually taking gingival shades, staining anything that's subgingival bright pink, or pink to match the not bright pink, but to match the gingiva. And we're eliminating, especially in the thinner biotypes, that shine through. The other thing we're doing with that type of abutment is, you think about a crown. A patient comes in and they have a crown prep, and the crown is 2 millimeters thick. If you try it in and you don't like it, your only option is to cement it and not like it, or you send it back because you don't have any control on cementation day. What we're doing with our abutments now is, instead of getting a crown prep, we're getting a veneer prep. So we're getting this implant abutment that looks like a veneer prep. Then we order the veneer, and now we're back to total control. This veneer is 0.5 millimeters thick. The abutment is, reduced 0.5 to 0.6 millimeters. Now I'm trying this veneer in.
Right.
If I need to alter shade, I just switch cement. So we're doing some cool things. It's interesting because we didn't talk ahead of time, but about the implant abutments and where we're going with anterior implants. 15 years ago, if you came into my office and you were missing tooth number 9, and you said, what are my options? I would have said an implant, but I wouldn't go that way, or a bridge, especially if you had a high smile line, because literally it was like, throwing dice in the air, and if it came up and I got a good number, then it would come out good. If not, I lost control. Where now, I think that if you came in, I would say, it depends on how much money you want to spend, honestly.
Right.
Or if you think insurance is going to cover it, that would almost be your decision making. Because I know I can get a great result with implants. I get a great result with metal-free bridges.
Yeah, it's interesting. These zirconia abutments actually make up a pretty small percentage of the overall custom abutments that we do, including in the anterior. Dentists, again, are showing that they're into strength. And so they get that the strength of a zirconia crown is the fact that it's monolithic and there's no porcelain fused to a metal. But they also get that same feeling you do when you're cranking down that screw against something that's ceramic. In fact, the one area where I still encourage dentists to use PFMs is if they're replacing a 3-unit bridge, especially for a lower first molar. As strong as zirconia is as a single unit crown, when you put it under the function like a bridge, unless we have a connector between the ponic and the abutment that's 3 millimeters vertically and 3 millimeters horizontally, it will break. And so the PFM bridge in an area like that where a patient won't have an implant or the teeth had an old bridge and they just want a new bridge still could work. But when you brought up the implant showing through the thin biotype, it made me think of one of the other great challenges. And as we finish this up today, I'd like to see if you have any kind of new spin on this. And that would be the endodontically treated central incisor. And when I was your student at LVI, we used to, one of the other instructors there had a ditch that he named after himself. I don't know if that ever caught on or not, but one of the things that we were taught to do when you've got that thin gingiva and you've got that dark root showing through, you can have the world's most gorgeous, Emax, even Empress crown on there. But all of a sudden, the gingiva still looks gray, like it's a PFM because of that really dark root. And we would take a round burr and try to drill down apically into, about a millimeter and a half back from the root surface on the facial and put a white flowable composite in there to try to brighten that up, and with kind of mixed results. You can do the walking bleach technique and sometimes get good results there. I don't know if you've got any recent tricks that have helped you with that, or is that one where you just take it out and put an implant in and go, well, we're going to have more bone around the implant than we did around that root?
Well, I think you're absolutely right. And actually, Bob Nixon developed that technique. Sometimes it works like magic, and sometimes it doesn't work at all. And it's really about the biotype and the darkness of the root. A few years ago, I had a patient come in. I thought that they had an ugly veneer, dark at the gingiva, dark subgingiva that you could shine through. Of course, I opened my mouth. It was a woman I met on a plane. I said, I could totally fix that. She comes down. I went ahead and did the ditch, and I cemented the veneer, and it looked pretty much exactly what she had before. I redid it a second time. It looked the same. And she had a very high smile line. She kind of wanted to go that modeling route. This was not going to be satisfactory for her. And so we pulled out the tooth, and the root was black. At one point she had a silver point, endodontically treated, she had a silver point, and then it got, from the hemorrhage, it got dark. And so that wouldn't work for me. That ditch did not work. And when it does work, it's like magic. So at that point, if a thin biotype and a dark root, there's nothing magic anymore. What's magic, in my opinion, is now I have a great alternative to a PFM bridge that I had to reduce 2 millimeters facially to get a great aesthetic result. Because again, you think like a ceramist, to get a PFM with an unbelievable aesthetic result that looks like a natural tooth. Right. A ceramist would tell you 2 millimeters.
Right, absolutely.
Not even 1.5 millimeters. So 2 millimeters. So now you come in with one veneer and an endodontically treated tooth, or a crown and endodontically treated tooth. And I say, okay, well, let's grind the other teeth down to little tiny pegs, bury the margins of gingival. Now we have the option of, Michael, I can do an implant that'll look unbelievable. I could do a winged bridge just on the lingual. It doesn't use metal. I mean, it's a Maryland-style bridge, but we could use Emax. We could use zirconium oxide. Or we could do a traditional bridge if you had some existing under-prep crowns on the adjacent teeth. We can replace that without grinding any more tooth away. And that's very exciting because now we have options. And I think for a lot of dentists, they struggle, me included, taking out a tooth and grinding down teeth next to it to, very reduced preparation.
Well, I know that 1 out of 6 dentists in America was sued last year, and 60% of those were for lack of informed consent. And you can just imagine where somebody has 2 teeth ground down for a bridge, one needs endo, the bridge doesn't look great, and then the patient finds out sitting next to someone on an airplane, you could have had an implant, and all of a sudden they're going, oh, what? I didn't hear about that. And the dentist really can't go anywhere, from that point, and you're kind of stuck. Was it with that woman? Was it was she easy to convince that this tooth should be taken out? Because I can see a lot of people going, oh, that sounds so drastic. Or did she really knew that the problem was the root and that's what was holding her back?
Yeah, I think she realized it was the root, but also she was motivated by aesthetics. And after trying twice, we realized that we're not going to get an improved aesthetic result. And as much as I hated it, at that time I thought, I hate to take this out. Actually, it was probably about 5 years ago. She was the one that said, can we just take it out? And it's like, you know what? I think that's the only option. This is a woman that has a high smile line, long premaxilla. She showed probably 10 millimeters of tissue above gingival margin. I mean, and she was a pretty woman. That was a huge aesthetic concern. And so, I did not have to convince her. It was like, let's get that thing out then if it's a problem.
That's great. That's because that was probably the right answer, but you could see some people going, whoa, extraction sounds extreme. So speaking of extraction, let me leave you with one thought and see if you think this is crazy or not. I'd like to see the standard of care for extractions change in the next 10 to 15 years so that every time a dentist removes a tooth, or in this case a root, there's always an implant placed into that space and then some bone packed around it and then closed up and let it integrate. And maybe some patients can afford to have the crown done as soon as that integrates, or maybe we're going to load it now with a temp out of occlusion. Or maybe they've got 2 kids in college and they can't afford to restore it for 5, 6, 7 years until the kids graduate. But at least the implant is already in there. And considering that a lot of GPs still don't want to place implants. They don't want to do that osteotomy. Well, this is nature's osteotomy when you take that root out. The hole's already there. We're just really getting some stability maybe in the apical third as we put that in there. What do you think about this idea about every time we remove a natural tooth root, we're going to replace it with a titanium tooth root so that they always have the option to have it restored later in life?
I think that's a great option. I hate to say every time because, dentists, and we both can say this because we are dentists, right. We get locked in. A patient comes in, it's got a huge abscess from an endodontically treated tooth, and there's pus coming out after the extraction, you shove it in. Or, I don't do my own extractions because I extract teeth like I'm taking out a fence post out of the ground. I push it this way as far as I can, I yank it this way, I'll kick on it a little bit, and finally it comes out and I destroy the buccal plate. And then if I said, oh, now I'm supposed to put an implant, it's obviously not going to be maintained. I think that situation will happen if they start teaching that technique in dental school.
Right.
Some of the leading educators are proponents of that. And I'm not talking about surgical educators. I'm talking about general dentists like you and me, right? And the dentist can afford to go to education because the average dentist isn't even putting any bone graft or any osseous material in there. They're extracting the tooth and dealing with the divot later on. So I think if we as a general dental population can be trained on that, be educated, I think if implants are made affordable, instead of costing $300 or $400 each, they need to be made affordable, which, companies like Glidewell, some of the other companies that have these knockoffs of some of these more expensive brands, then it is an option. You come in and say, for $200 more, I'll just fill that with this little metal thing, and you could leave it the rest of your life, or you're right, when your kids graduate from college, when you win the lottery, when you sell your car, whatever it is, now you have a great option versus going through all this again.
Right. It seems like it's an easy thing for a patient to accept the concept of, we're going to take out your old decayed root and put a new one in. Not a human one, but a replacement one that won't decay because it's made out of titanium. Well, David, thanks so much. I appreciate you spending.
Can I leave you with another thought?
Yeah.
Because I know a lot of your educators, or a lot of your dentists call you for advice on dent bonding agents and what to cement things with. And laboratories, they say up to 41% of education on adhesion is given by a ceramist, to these general dentists. So I know you're going through that all the time. And, I'm really excited. And we talked earlier about some of the things I'm excited about before this conversation. I think that dentists need to look hard on these new universal bonding agents. I'm a total etcher, and you're not going to change my mind, right? And I always say 4th generation is the best. Bond 3, Octobond FL, Scotch Bond Multipurpose Plus. And we have 25 years clinicals. When I cut off some veneers I did 19 years ago, I cut them off last week, and it was a nightmare. And they were on dentin. And it was a nightmare because I think I total etched, I use a 4th generation. And then, manufacturers went to self-etch, and some of the early self-etch were good. And then the 7th generation adhesive, these single bottle self-etch, I think were a huge problem, but they were easy, and we're lazy by nature. They were easy, and the manufacturer said, oh yeah, they definitely work with no long-term studies that they could show us. The new 8th generation, these would be, Reliax Universal Bond, Ivoclar has Adhes Universal. I like Viscose, they're all bond universal. Kerr has all-in-one bond. There's different manufacturers. They're a totally different breed than the previous single bottle systems. And so I would ask, especially your dentists that are looking for good systems that I think are going to be very predictable, that are also easy to use, to look at this new universal category of bonding agents. I think they could use it as a self-etch, a total etch, select etch. So they've got some options, but they're much different than the 7th generation, the single bottle system. So I would ask dentists out there to do themselves a favor as well as their patients, is look at this newer generation.
That's the first time, because I kind of agree with you. That's really the first time that a later generation has actually gotten better. To me, it seemed like, you and I both grew up with the 4th generation, and it made total sense, and it did work very well, the 2-bottle systems. But it seemed like the generations after that were more about convenience for the dentist than a better product for the patient. And whenever we see that, I always get suspicious. We always think it's a step forward. Even cements, where you have the paste clicker like that, they don't release nearly as much fluoride as the same cement in a powder liquid where you mix it like we did in dental school. So that's even a compromise right there. And it kind of scares you, because what's an 11th generation dent and bonding agent going to be? You just cure after you prep it, or you put some on the air water syringe and blow air through it, and that's going to place that. So you worry that it keeps getting away from that. So that's good to hear you feel that way. Are you still teaching courses down in your office or next to your office?
I am. We're doing over the shoulder. I realize the demographics have changed a lot since you went through LVI and then Hornbrook Group and even Pack Live, where courses were $10,000. You spent 9 days with us, 9 days out of your practice. I mean, you learned a lot, and I think that you and your peers that went through these courses with me would say it's one of the best things they did, best use of money in their lives. But, the economy has changed.
Right.
The demographics of these young dentists, you get out and you owe $400,000, right, and now you see me lecture and say, I want to go spend 9 days with them, here's 10. I mean, it's just not going to happen. So my focus the last couple of years was to become very accessible and very affordable. Where my over-the-shoulder courses, I limit to 10 doctors, where I still do the smile design on a patient. I prep, I provisionalize, I seat the case, but now you're over my shoulder. You can ask as many questions as you want. You can put gloves on and feel the preps. But it's $1,800 instead of $10,000. It's 1 day out of your practice. So I'm doing that. And then Mark Montgomery, and I know you, Mark, Mark, which is certainly one of my mentors in functional dentistry. Right. We've gotten back together, and we have a 3-part series now on functional aesthetics, from smile design to pain control, throughout these 3-part series. So very excited about it. It's in San Diego, very small, intimate settings, 10 to 15 docs. I'm going to make a plug. Doctors that are listening can go to davidhornbrook.com and look at some of our schedules, or when I'm lecturing again, it may be in a city near them. But we're very excited about it.
Yeah, and I'll certainly give it my endorsement, because I've done plenty of educational programs with you. And, I do think the ultimate in education is dentist brings a patient, dentist works on a patient, but it's so complicated that really there's not any of those classes really going on anymore, and it's incredibly expensive flying the patient out there and back, and really, it almost makes it undoable. But when you look at over-the-shoulder education like that, that really is what I consider to be the best, to be there and be able to see it live and know there's no edits. There's no way to do like live Photoshop as you're trying in crowns and veneers. That hasn't been invented yet. So it is a great way to do it. And having spent a lot of time in your courses and next to you at courses, I can wholeheartedly recommend spending a day with you. And I like that idea of doing it in a day and not a 3-day weekend, or 2 3-day weekends. I mean, I could see orthodontics needing that long, but aesthetic dentistry, I'm glad to see that you've wrapped it up a little bit tighter than that. So that's fantastic. So again, that's at davidhornbrook.com if any of the doctors out there are interested. David, thank you for spending a little time with us this morning. I look forward to bumping into you again somewhere soon. And almost above anybody else, thank you for your commitment to quality dentistry and being an aesthetic guru for the rest of us.
Well, thank you, Mike. I want to thank you for putting this on. I know you're taking time away from your family and your friends, and here it is a Friday morning, and you're educating other dentists, which I think is so important.
Very good, David. I appreciate it. I'll talk to you soon. Thank you.
And again, if you haven't had the opportunity to hear him speak or spent any time with him doing an over-the-shoulder or a hands-on course, you owe it to yourself. David, as far as aesthetic mentors go, in my experience, is the most down-to-earth and really non-judgmental and will help you all the way through. There's a great story about when he was teaching me at a class, a live patient class, where I bonded in a couple crowns with a dark retraction cord, and he said, he nicely said, congratulations, you're the first dentist to do an all-ceramic crown and make it look like a PFM with a bad metal margin. So we bonded over that, and he continues to be one of my good friends and certainly one of my big aesthetic mentors. So go to davidhornbrook.com. It's HORNBROOK, davidhornbrook.com. If you're looking to step up your game in terms of aesthetics, he will definitely be a guy who can help you do it in his office and his teaching facility as well. That about wraps it up for episode 110. On behalf of myself, the CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry. Congratulations, you're the first dentist to do an all-ceramic crown and make it look like a PFM with a bad metal margin.